calcium, on cholesterol. It just goes down into the artery. Any small artery, diffuse diseases, it can open any block. No need to put stent. Do a laser, put DCB, drug-coated balloons, patient is done. And you repeat your angiography. It is meant for those frail, diffuse disease patient or any patient who doesn't want surgery or any stent. Then laser is taken. Then we have a penumbra device for deep vein thrombosis. When oral anticoagulation is contraindicated, we get a lot of DVT patient, obese patient, post-surgical, post-pregnancy. We have a lot of DVT cases. So that this is a device which can remove clot from femoral vein. You go from one femoral to other femoral. It is a suction device. It can lower the burden of that clot. Then you can give small oral anticoagulants. Or when anticoagulation is contraindicated, this is the treatment of choice. These are the plaque modification tools which I discussed: IVL, laser, cutting balloons, rotablation. I will not go into details of this. This is a Shockwave lithotripsy. I will show you one example. This was a 74-year-old male, hypertensive, diabetic, CAD, and he came to us with classical angina symptom, pain on walking. We did his angiography. So you see here, yes, this is moving. So this block, if you see here, you have that place. So here is a block. Why actually cursor is not moving here? It is. So you can see the tortuosity there. There is a block on the upper part. Then we ballooned it with IVL balloon. This is OCT run. You see, this is optical coherence tomography. You see the beauty. You can see the yellow plaque, the consistency of plaque, and here the narrowing is there. So it is just a 10-minute job, and the camera moves like this from distal to proximal. You can assess the size of the artery, size of the plaque, composition of plaque, calcium assessment. You can do anything whatever you want. So we did IVL, and then this is the IVL balloon, simple balloon. We break the block, put a stent, see the tortuosity on this stent. And this we take post-procedure run also just to see how our stent has been put. Many, this is final results. This is another case. So this is a great innovation. Next innovation was impeller device. In any person who has got high risk for open heart surgery and who has got low ejection fraction, like less than 35%. So there is a device called impeller. It is like an artificial heart. So we put that impeller device inside the heart, inside the LV, left ventricle, and that actually pumps, take out blood from left ventricle and ejects into the aorta. So it is basically assisting weak heart, that poor function heart. So that we can do our procedure. You can put multiple stents, you can open all three arteries. So what the patient is on? Artificial heart. This is called impeller. This is an impeller. That blue device, the curved device in heart. This is called impeller. So it is like a motor pump. Like you take out water from land and it can lift water to second or third floors. This is like that. It is like a pump. So it takes out blood from LV and ejects into the aorta. Heart can rest. So 50% of load to heart is reduced because of impeller. It is costly, but it has benefit. People who don't want surgery, or those who are not eligible for surgery, like high risk patients, very frail patients, low ejection fraction, low pumping power, for such patients. So this is the block. This was an angiography. You see multiple blockages. All arteries are blocked. Then we put a wire in LV. This is left ventricle. You can see the door of left ventricle. And then we put a wire. We place an impeller pump. This is called impeller pump. The beauty is that after procedure you can actually remove impeller. And now this impeller device is class 2 indication for cardiogenic shock patients. And class 1 indication, if the patient presents within 6 hours of cardiogenic shock, when there is no lactic acidosis in AVT, then this is going to help, this is going to save that patient. Because the cardiogenic shock mortality is around 60 to 70%. Still the best of the operators, best of the techniques, best of the staff available, even then the mortality is 60-70%. So this impeller device is now class 1 indication for patients with myocardial infarction with cardiogenic shock. So what is shock? Any patient on non-adrenaline, any patient who requires inotropism shock. That is the definition actually. So even if any person who needs 2 ml or 1 ml of non-adherent, he is in shock. That is why, that is how you can prevent him from dying. You can say mortality, because when you look at the mean arterial pressure, it should not be below 70. You have to raise that blood pressure by either inotropes or impeller. So impeller gives you that chance. Then we did IVUS. This is IVUS, which I was telling. You can see the innermost thing, the rounded thing is camera, and you are doing IVUS there. And the beauty is that this IVUS doesn't require any dye. This is very good technique for those patients who have got high creatinine values, like CKD patient, acute kidney injury patient, when you don't want to give dye. Dye is an enemy for kidneys. So we can do low contrast or no contrast angioplasty. You can see blockages from this, and you can just bookmark where to put the stent, what's blocked, which break and broken. That is how it actually makes a difference in our interventional procedure. And then we put stent. Then we are putting stent. Now I would like to show you one thing. This is very important. See the block in the upper artery. There is no flow in the upper artery. Stops. So at one point of time, this patient, there was no flow in left main artery. His one of artery got total occluded during procedure. Had I done this procedure without impeller, the patient would have crashed on the table, but impeller was there. So there was no BP on the monitor. The heart was not beating, but impeller was there supporting his all organs. So that is why he was awake without ventilator, no cut. It is like doing his coronary bypass grafting while patient is awake and non-surgical. So this is how we did this plasty, and patient is very well now. He was a farmer actually. He sold his land to afford this. This cost around 25 lakhs in my country. It is quite costly, but people actually can pay when it comes to your life. So other thing is metal-free angioplasty, which I was discussing. So we are not putting stents in now in younger patients with medium artery blockages, like in branches, OM, diagonals, or mid-LAD, distal LAD. When there is medium-sized vessel block, we are not putting stents. Because stent is metal, and you can have thrombosis, you can have restenosis. You are changing the shape of artery. Now this technique has come up. This is called drug-coated balloon, and it is now class 1 indication for in-stent restenosis. Whenever there is blocking stent, you just balloon it. After doing IVUS, you just balloon it to DCB. This DCB deploys medicine over that area, and then you can just do away without putting a stent. This is a case I will discuss with you. You see, we are blocking that, we are just ballooning that block. So this was a patient, this patient was a doctor himself, and he came to us with high bleeding risk. Like he was thrombocytopenic, he had portal hypertension, he had cirrhosis, alcoholic, platelets were low, and he got this LAD block. This LAD block, see there. Acute coronary syndrome, troponin high. Now what do you do? You can't put stent because platelets are low. His portal hypertension. He had varices. 1 month back, endoscopy was done. He had varices. He bled. His hemoglobin was 8. What to do now? So we did this drug-cutting balloon angioplasty. No stent. We put just a drug-cutting balloon, the drug-coated balloon, and this is not indicated now. It is not one-day indication because it is the main artery, but we did for this case. And now there have been they are conducting new trials now that main arteries can also be actually opened with DCBs. This is very good, and he was sent home for only one antiplatelet, D-plat, clopidogrel, because aspirin he had varices and sulfate. So we did give. And after 2 weeks we stopped D-plat also. And when he came back to me after 1 month, his platelets were up. He was still. So we can actually do away with only one antiplatelet or even no antiplatelet just to get out of that crisis. Other innovation is lead test.